to start from the very, very radical question why we happen to be so serious about hyperdivergent face. You know what hyperdivergent face means? It may mean very long face, but on the other hand, hyperdivergent face doesn't have to be very long face in many clinical situations. I used to be a very good student back in the orthodontic program. I read a lot of articles. I studied a lot. And I followed the way how it is written in the textbook. So here's an 11-year-old girl. What do you think about her face? Do you like it or not? Yes or no? No. Your no side. So we have to do something for her face. So how would you classify her face? Is it class 1, 2, or 3? Absolutely, class 2. Is that correct? What are we supposed to do? She's class 2. Okay? She hasn't over yet. According to the textbook, we have to do something like high pull headgear. So we use the high pull headgear, we use the activator, we use the median screw in the mandible because the mandibular arch was narrow. And finally, we put braces on the teeth and we arrange the teeth and match the top and bottom in desired way. Now, do you like the occlusion? Do you like the teeth? Yes or no? Yes or no? Yes? You like it? How about the face? You like the face or not? You like it? Yes or no? You like it? Maybe not. Maybe not. Why? Because she didn't like her face for herself. Her parents didn't like her face after all 2 years of treatment. Very bad. I feel bad. What was the problem? She showed a very good cooperation with the high pull headgear, ionator, activator, everything. So was there a problem in her jaw growth? Let's have a look. Was there a problem in her jaw growth? Do you see a lot of jaw growth? Yes or no? On the right side, have a look. There's a tremendous growth. Okay, our growth modification worked, but it didn't seem to work on her face. Some problem. Growth worked, and all the appliance worked without any problem. So, I'm feeling a little regretful. It didn't have to be extraction. Maybe it had to be extraction of the premolar. But we didn't seriously consider extraction because her upper incisor axis was very upright even from the beginning. Okay, that's a limitation. Let's have a look at another case. 12-year-old girl. Now she has a combined protrusion and crowding. Again, the common thing between the first case and the second case is that they had a little bit slightly wide mandibular plane angle. That's what we call hyperdivergent face. Now, this is a combined protrusion and crowding. So, we did not hesitate to pull out premolar. We will pull out the premolar. And just because I was a very good student, I decided to go for mini screw for anchorage preparation, reinforcement. So we use the mini screw to prepare the anchorage, and we are almost at the end of our space closure. Now you are expecting a little better profile. What do you see? Before, after retraction. Do you like the face? Yes or no? You don't like it. Very bad. Did I do anything wrong? At least I can say I did my best according to textbook because I studied very hard. I used the conventional hyperhead gear in the first case. I used the mini screw for the second case. I used I tried extraction of the premolar to gain the maximum space. I tried my best to retract the incisor, and this is a result of incisor retraction, and she's not happy. So this is a result of following, sticking to the orthodontic textbook. What was wrong? What was wrong? What do you find? First thing, was there a limitation of an incisor retraction? Yes, there was a significant incisor retraction. Was there a problem of molar anchorage? No, the molar was staying at the original position from the beginning to the end. What else do you find? Maybe the growth, vertical growth. Okay, you cannot resist the growth, so it's your fate. You are supposed to be growing just like that, and it's not my fault. You can make an excuse, but we don't feel very happy. And now she's growing until 15, and she feels miserable. Are you still interested in orthodontics? Yes or no? You want to experience the same thing that I experienced? Making the patient miserable at the end of the 2 to 3 years of orthodontic treatment. Very bad. What was the problem? There's no problem. The only thing is I followed the textbook. What is written, what is taught in the textbook. Well, she is still protrusive, so we have to be serious about some type of a face, hyperdivergent face. Hyperdivergent face. Because the conventional guideline doesn't seem to work. Hyperhead here, extraction, everything doesn't seem to work. We need to find a little more creative remedy. Like what? Hyperdivergent face definitely has some problem in the structure. Okay, let me ask you one question. If you have occlusion like this, so how do you classify? Is it class 2 or class 3? Absolutely very serious class 2. Is that correct? Yes or no? Class 2. Okay. And make a guess. Whose teeth these are? I mean, whose tooth, whose occlusion this is? The right one or left one? Very serious class 2. Number 1, number 2. Whose occlusion is this? Absolutely. Okay, raise your hand. Number 1, how many of you choose number 1? How about number 2? Okay, I have more number 2 because this is a terrible class 2. The right answer is number 1. You get it? Right answer is number 1. Number 1. What was the problem? Make a guess. Now, again, another question. Whose occlusion this is? Whose occlusion is this? Number 1 and number 2. There's only one choice, number 2. Of course, well, this is a class 3 occlusion. Class 3 occlusion with class 2, very serious class 2 face. Do you understand? Do you understand? Now, my point is, hyperdivergent face is a vertical problem. And if there's a vertical growth, whether it's a clockwise or counterclockwise, it produces very serious mismatch between the face and the occlusion. It's a big, big problem. Very big problem. Have a careful look. You may have an image that class 1 occlusion may have class 1 face. Class 1 face will have class 1 occlusion, but it's totally different. Many times, class 2 face would have a very good class 1 occlusion, and class 3 face would have a very good class 1 occlusion. Especially when it comes to hyperdivergent face because of the vertical growth. Okay? If it's a hyperdivergent face, it will have many times very serious class 2 or class 1 or class 3 occlusion. Now, the first case is a combination of terrible class 2 with class 2 occlusion. Second case, combination of a very good class 1 occlusion with class 2 face. Third one, combination of very terrible class 3 occlusion with class 1 face. You want to try mandibular advancement for the second case, surgery again, just because it's a class 2. You want to try? Okay, you can correct the face, but you will mess up the occlusion. You want to try mandibular setback surgery for the third case? Yes or no? Okay, you can correct the occlusion, but you will mess up the face. This is a very, very big problem. By the way, did you ever get into this kind of information in any of the orthodontic textbooks? Not really, not really. This is a bit of a problem. If you stick to the orthodontic textbook, you will experience some radical trouble in real situation. Real situation is your clinical practice. Are you still interested in orthodontics? Orthodontics is terrible. Many times you end up with a very bad result, but still we need to find the remedy. We need to find a remedy. What seems to be the problem with the hyperdivergent face? Okay, hyperdivergent face causes discrepancy between face and occlusion. Correction of one will kill the other. Okay, this is and from the bottom line, this is a vertical problem, not necessarily anterocloser problem. So if it's a vertical problem, you need to have at least some vertical remedy, vertical treatment protocol. Because we experienced something like this. Patient came, she's in her 20s, very good occlusion. What was the problem? She doesn't like her face. Okay, now we are ready to pull out premolars. How about her premolar? It's already gone. Why? Because she had orthodontic treatment before, some years ago. We are not supposed to pull out the second premolar. That's too much. So she's complaining. This is the result of orthodontic treatment. What am I supposed to do? What about the vertical relationship? Her mandibular angle was 47. And her upper incisor axis was 96 compared to the normal range of 105, 106. She has a very upright upper incisor. We are scared of additional retraction. We're not supposed to retract the upper incisor anymore. And even if we did that, we'll have only 1 or 2 millimeter retraction of the lip that doesn't really help the improvement of the profile. So what do you think? If this was your case, you still have to make the decision whether you will start the treatment today or not. How many of you would start any kind of orthodontic treatment today for this patient? How many of you would start the treatment? Raise your hand. Oh, no one? How many of you would not do anything today for her? Okay, you are clever. You will have a very good life. That's a very good answer. You better not do anything for her, but we did something. Okay, I'm going to skip this. This simply indicates the limited soft tissue change according to hard tissue movement. We did something. Oh my God, you place mini screw here and there. How many mini screws did you use? 6 of them. Okay. Too many mini screws may trouble you, but I believe in something before and after treatment. Was good occlusion at the beginning, still good occlusion in the end. So what was the difference? What was the difference? In the panoramic view, at least we did not pull out additional second premolar. Okay, we saved all the teeth, at least, but we pulled out third molars because they are useless. What else? I see just a little bit of root resorption, which is an evidence of additional orthodontic treatment. but there's a significant change in the face. Do you see some change? This is a result of a second orthodontic treatment. What did we do? Well, some minuscule combination of a minuscule and a bracket and things like that. No, it's not about minuscule, it's not about bracket, it's not about type of the wire. It's all about the way how we manipulate the whole appliance, biomechanics. What did we do? A lot of retraction. No, there's something else on top of it. What did we do? Have a look. Now I satisfy her. She's happy. What about the change in the face? I don't know. Well, it looks like there's some retraction, but what is important is this one. What is that? Yes, there was a retraction. There was distalization of the molar, but what is more important is the reduction of the whole facial height. Total arch intrusion. We call it total arch intrusion. We do the intrusion for open bite, but this case was a rather deep bite. Does it apply to deep bite? Yes, as long as you have soft tissue problem. We decided to go for this total arch intrusion just because we noticed there was a soft tissue problem in the very beginning of the treatment. It has nothing to do with the number itself. I noticed there was a soft tissue problem. What is that? This is what we call soft tissue incompetence, lip incompetence. We noticed there was an incompetence. We read something wrong from her face. That's why we designed some radical total arch intrusion, backward and upward in both arches. In the maxilla, backward and upward translation of the total arch. In the mandible, backward and inward. Downward, backward and downward total arch intrusion in the mandible. Why? Because we notice a serious discrepancy between soft tissue and hard tissue. Have a look at the length of the arrow and have a look at the discrepancy between the length of the soft tissue and dental alveolar hard tissue. We need to match them. We need to make them even, comparable. So how do we do that? We cannot possibly enlarge the lip. We cannot do that. We have to reduce the hard tissue volume. Like what? We can pressurize the upper arch and lower arch, backward and upward, downward and backward, and something like that. Is that going to be possible? I've never imagined something like that. Yes, it's possible because we've done some research. So now, there's a common feature between meal and soft tissue. If there is a redundancy, of the soft tissue, there's no problem. If there's a shortage of the soft tissue, it always causes some problem. So soft tissue incompetency means there's a discrepancy. Soft tissue is not long enough, not large enough to cover up the underlying hard tissue. Then it causes a problem. So you need to do some manipulation of your hard tissue. That is the main thing. So we need to actively control the vertical dimension in real situation. And very unfortunately, no one seems to be talking about the vertical control, at least in the orthodontic, very conventional orthodontic textbook. In fact, a lot of well-known orthodontists have mentioned, commented about the vertical control. Even from the Tweed Merrifield, Tweed something, there was always kind of a trial or attempt to control the vertical dimension. The only thing is, the trial didn't seem to be very successful, and there are reasons. So, when we discuss the intra-arch issue without lip incompetence, for example, some gummy smile, you may think about segmental intrusion of an insider segment or something. That is already very well described in the orthodontic textbook. But what we have to focus on is the total arch control. And that applies to many patients who have the radical soft tissue incompetence. So how do you recognize the incompetence? You ask the patient, okay, close the lips, relax, And you can practice this to the person sitting next to you. Ask the patient, okay, relax, relax, and then you will measure the so-called freeway space between upper lip and lower lip. If the distance between upper lip, lower lip, it exceeds 2 to 3 millimeters, we diagnose, we recognize that there is a soft tissue incompetence. We need to do something, and it doesn't have to be, well, huge amount of retraction. No, it's a vertical control. Okay? So now you recognize that there is a vertical problem, and you will have to do something. Now, are you ready to give the patient a HIFU headgear? Even if your patient is turning 25, 36, you're still going to use the HIFU headgear, yes or no? That's too much, right? You're going to have to think about soft tissue. Soft tissue is different from hard tissue structure. From now on, you better not stick to the number you can find from cephalometric analysis. Okay? How? Okay, let's think about HIFU headgear. And you will keep nagging on patients, asking them to wear it 24 hours a day. Is that going to work? Do you think you can wear the HIFU headgear for yourself 24 hours a day? Can you do that? If you cannot do that, don't ask your patient to do the same thing, right? You're not supposed to ask the patient to do what you cannot do. That's not fair. And it's not from a meta-analysis and systematic review and everything. It turns out that the HIFU headgear and all those conventional appliances do not seem to work when it comes to vertical control. Why? Because of there's a collaboration issue. Patient doesn't seem to wear them very much. And another thing is the suture biology. Even if you give constant pressure against the suture will not go away. They are there. So doesn't seem to work. What is alternative? Probably you can try surgical intervention. You go towards surgery around here. Only for the sake of lip protrusion? Only for the sake of lip incompetence? No, that's too much. That's too much. Instead of that, I would go for dental alveolar correction, which I can do very well with some kind of confidence. So, I do a lot of total arch intrusion, and there is research background. Well, long ago, we tried to compare the amount of distalization in 2 different settings, 1 minuscule versus 2 minuscules. Of course, in terms of amount of molar distalization, you will end up with a little more distalization when you use 2 minuscules. But on the side, as if it's a byproduct, using 2 minuscules, we noticed that there was not only distalization but also intrusion of the whole arch. Okay, and we try to analyze the mechanism, and if you use 2 minuscules, because there is an additional force vector, the 2 force vectors seem to embrace imaginary central resistance of the whole arch. Have you ever imagined manipulation of the total arch using the center of resistance of the total arch? No. So we, again, working with another group, we try to localize the center of resistance of the total arch using a finite element analysis. Okay? Although this is not really precise, I think it's dependable. The information we got from here is dependable, reliable. So center of resistance in non-expression model was found around the second premolar in the maxilla, and also we did the same thing for the mandible. And based on this kind of calculation, we can assume where we have to place the minuscule when it comes to total arch intrusion, right? The center of resistance of the mandible was localized between the second premolar and the first molar. And because of the shape of the alveolar bone, when you want to move the teeth backward, and also downward, it has to be oblique direction. You cannot possibly move them directly downward because your incisor will develop some bone recession. Is that correct? So when it comes to total arch intrusion, at all times, it has to be oblique movement of the total arch. So we can estimate the force system in this way. And we also tried another finite element study to see, at least to simulate the type of displacement depending on the force vector. Again, it was supposed to be the pattern of the destabilization if you give this and that destabilizing force, but on the side, you noticed that there is a significant opposite plane rotation. Alright, although we haven't imagined that we could manipulate the total arch in this and that way, now we can assume that it is possible. It is possible, and it can be very sensitive function of the force vector relative to the location of the central resistance. So we have to plan and we have to design the force system before we do something. Here's an example. Okay, there is an open bite. You know how to intrude the molar segment. Okay, probably you need 1, 2, 3, 4 mini screws, but we always think about the minimum number of the mini screws. So this may be a very clever solution. This is my friend's work. He decided to use only 1 mini screw along the mid poly. Okay, you are clever. Let's have a look whether it works. Did it work? Incisors extruding, and the molar segment intrusion doesn't seem to be very even anteroposteriorly. There's a rotation, and also there's a significant, very tremendous difference in the movement of the first molar and the second molar. Do you see that? Okay, at least theoretically, this was a clever approach, very clever. So we don't have to use many mini screws. It doesn't have to be 4 or 6 mini screws. Only 1 mini screw will do the work, at least theoretically, but the reality was different. Why? And the actual clinical outcome was not very satisfactory. We were supposed to see tremendous, at least molar segment intrusion, but as you see, only first molar has been intruded and second molar was there, which is why we don't seem to have a very significant auto-rotation of the mandible. So, this is not effective. Why? We also have to think about the shape of the target segment. When we deal with anteroposteriorly long segment, many times if you want to move anteroposteriorly long segment to the vertical direction, you need a very tight control, very precise control of the force in the anterior and posterior part. So even if we deal with the same identical segment, depending on the force direction, our strategy will be different. When it comes to molar distalization, maybe we can use only 1 mini screw on each side. But when it comes to intrusion of anteroposteriorly long segment, basically we need multiple mini screws. Unfortunately, that's the wisdom we can get out of the biomechanics. Different. Although we deal with the same identical total arch segment, depending on the force direction, our strategy will have to be changed. And this was evidenced in one of the study done by Japanese group. They tried to intrude the molar and premolar segment in a dog model. They used 2 mini screws. Even if they used 2 mini screws, depending on the force balance, there was a tremendous difference in the type of rotation of the molar segment. So, this is different. total arch intrusion may be technique sensitive, but it works, and it demands a little bit of understanding on biomechanics. So the bottom line is, when you deal with anteroposterior long segment to the vertical direction, unfortunately, you're going to need a multiple point of force application. So that's why I still use a multiple meniscus when it comes to total arch intrusion. Whatever you do, you have to do it very smart way. Do you think this guy is smart? Simple but not very smart. Right? I know you want to minimize the number of the meniscus, but as long as it has a very good scientific background. So this notion is applied to many cases. I think I showed you this case many years ago, also in Vietnam, I don't know, in Thailand. This is a representative case that shows the power of total arch intrusion. And this is very terrible. Protrusion, class 2. But somehow, she had a very good class 1, even close to class 3. Very bad. She had a very terrible class 2 face with a terrible, very good class 1 occlusion. How does it, does it really make sense? It makes sense because she has a very serious vertical problem, hypodilated face with mandibular plane angle of 58 in the very beginning. So, what are we supposed to do? Basically, we can try surgical intervention or whatever, but what bothers me is that she has a class 1 occlusion. Okay, we can still try premolar extraction, but what is important is that we have to really focus on vertical correction. So we will try total arch intrusion. We'll design the force system, and we know where the center of resistance is located. And I want a little more intrusion in the posterior segment than in the anterior segment because she had an open bite. So I will use 2 meniscus, and the resultant force factor will pass a little bit behind the center of resistance of the total arch. We design these kind of things, and then we get the result. After extraction, we have 1 meniscus on the buccal side, another meniscus between 6 and 7 on the palatal side to keep the balance between buccal force and the palatal force. And this is the result. And now you are curious about the change in the face. And this is a change. This is a change. We're gonna have to get something like this. Otherwise, you'll be ruined, you'll be frustrated at the end of the treatment. And normally, orthodontic treatment takes you a very long period of time, 2 to 3 years. So we have to plan everything ahead of time. How was this possible? Because we designed the total arch intrusion together with the maximum retraction of the upper and lower incisors, but without the vertical control, we would not be able to gain this kind of result. Is that going to be stable? At least occlusion-wise, it's stable for the next 6.5 years, but we see some change in the profile over time. That is supported by one of the articles we have published. Okay, intrusion may be subject, especially the molar intrusion may be subject to some certain degree of relapse over time, which is around 20%. We have to think about that. So we will consider retreatment at certain time point, or we'll have to see the change in the face. But so far, from a clinical standpoint, very few or none of the patients really call for retreatment. But we are willing to do the retreatment if the patient wants, and we know how to do that. So it's not a very big problem. And my conclusion is total arch control, total arch intrusion is clinically doable, worthwhile. What do you think about his face? Asymmetry. Very serious asymmetry, right? What do you think about his face? Do you like his face? Yes or no? Not really. And he doesn't like his face either. Why? Because of protrusion? very severe flaring. Let's have a look. There's a deep curve of speed. What about the upper and lower incisor axis? Upper incisor axis was 93 point something, 90. Okay? Are you willing to pull out the premolar? Yes or no? Not really. So this is a very bad combination of upright upper incisor with a protrusion. So what is the name for this kind of face? There is a name for this kind of face. Do you know? We call this terrible face. Very, or alternatively, we call it very bad face. I hate that. You hate that too. And we are obliged to pull out the premolar because he was already missing, he was already missing lower premolars. Okay? We are obliged to pull out upper premolar, and we are very concerned because of the upright upper incisor. You know what is even more terrible? He's demanding lingual orthodontic treatment. Invisible. Very bad. How is that possible? Because he's Korean. Korean patients are always demanding, I need this, I need that, I need this, I need that. I want everything without surgery, without any visible appliance, something like that. Very bad. We have a lot of terrible and bad patients in Korea. But we still have to find a solution. I had to do lingual orthodontic treatment for this case, following leveling alignment, extraction of the premolars. We do the retraction. Oh my God, I am concerned because of her. His incisor was very upright at the very beginning. Anyway, I was barely able to finish the case in this way. Well, decent occlusion, class 1. What do you think about his incisor axis at the end? Not very terrible, not very terrible. Okay, we close the gap without serious tipping of the premolar. Okay, root alignment was okay. And what about the upper incisor axis? Okay, very well maintained. At least we tried. Translation. What else do you find? We tried our best, the best of the best of the best to gain maximum vertical control. That was what was important, and we gained. And as a result, we couldn't possibly handle the asymmetry. No, it was there, and it will be there even after treatment. But at least we can say we got rid of gummisma, first thing, and we got rid of underlying soft tissue incompetence by intruding the whole arch by max. Well, as I told you, asymmetry is still there, but we were able to control the vertical dimension to improve the face. Now, what do you think? He's got flat profile at the end of treatment. How was it possible? Because of the maximum retraction? No. The soft tissue change in response to maximum retraction will be very limited. We need something else. What is that? Vertical control. So the question is, would it still be possible doing vertical control with lingual appliance? This is working evidence. You can do that. And here's my protocol. We're going to have to, now that we localize the center of resistance of the maxilla and the mandible, we can design something like this, even if it was a lingual orthodontic case. Can you do it with a very brand new, very expensive orthodontic brackets? No, it has nothing to do with the type of the orthodontic bracket. Do you think we can do it with clear aligner? I'm not sure. There's another compliance issue, which is why I don't seem to use a lot of aligner, because we have so many terrible cases in Korea. And please try to focus on the circular arrow up there. What did we do? I twist the wire. Normally I twist the wire for incisor. Okay, let's have a look at the clinical cases. Class 2. He is a class 2. Do you think we can advance the mandible
He's a 26-year-old male. Do you think we can advance the mandible? Yes or no? Of course not. We cannot possibly advance the mandible without surgery. But he expects some change in the profile. My gosh, he has a very serious class 2 molar, crowding, everything. But this is the result. Do you see the change in the profile? Yeah, and mandible has come forward, and there's no Photoshop manipulation or anything. This is a real photograph. How is it possible? Okay, we pulled out premolars, that's one thing, and another thing is just because we did something like this, multiple mini screws, trying our best to intrude the whole arch using multiple mini screws, and this is a result, and this is a result. Okay, have a look at the upper lip change in response to maximum retraction of the upper incisor. There's a tiny little amount of retraction of the upper lip. Unless this is combined with advancement of the mandible, by elimination of the underlying soft tissue incompetency, you would not be able to see some change in the profile. So this is really important. What do you think about her? Do you like her face? Very bad. And surprisingly, this is the result of orthodontic treatment. Why? Because the orthodontist who treated her was planning some orthodontic surgery. Okay, so according to the orthodontic textbook, he pulled out lower premolar to maximize the overjet. And my concern is, first thing is that she doesn't want surgery at this point. Second thing, even if we commit a surgery, we couldn't possibly get rid of the underlying incompetence unless you design 10, 12, 13 millimeter superior repositioning of the maxilla. Very, very terrible. Very terrible. So, do you think you can recognize the amount of a soft tissue incompetence over here? Yes? Right? More than 10 millimeter. Very terrible. We call it very, 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 very terrible case. Okay? And her upper incisor was upright. Okay? That's commonplace. And we do the same thing, and this is the result. And this is it took me 4 years. 4 years. Very bad. I don't want to do the same thing again, but in times of trouble, we might have to do something like this. And what matters is, first thing is a total arch intrusion, and second thing is just because her upper incisor axis was very upright, we need to think about incisor control. Many times, hyperdivergent face has upright upper or lower incisor. We need to move the root. And I already published in the case report back in 2014 to highlight the best, the simplest possible way to control the upper incisor. The third combination, torqued arch wire together with the mini screw. So we do this many times. And we also developed a torqued wire, which is still flat, but torqued arch wire up in the front. And this is effectively applied to many of the hyperdivergent faces because the distance between the force factor to central resistance of incisor will become large, and we definitely need some additional torque on upper incisor. Which is why I use 18 slot rather than 22 slots for better control of the upper incisor. Okay, let's move on to class 3. What do you think? Do you like her face? Yes or no? Very bad. Would you believe this is the result of orthodontic treatment? Result of orthodontic treatment. Class 3, asymmetry, very terrible protrusion. Class 3, okay. In class 3, you are not supposed to intrude the whole thing because you will end up with the auto rotation of the mandible that will make the face even worse. But what else do you find? Okay, lower incisor is upright, but we do the same thing. Okay, root alignment was okay. Now, what do you think about her face? Do you like it better? Yes or no? Yeah, we did total large intrusion. Okay, there was an intrusion. Why intrusion in class 3? Why intrusion? Because we had an incompetence, vertical problem. So vertical problem is very serious, whether it's class 2 or class 3. And we published an article in KJO early this year to compare the effect of translation on the soft tissue change. And very interestingly, lower lip change was even more significant than upper lip change. So we're going to take advantage of this. We're going to take advantage of this, and we really did for this class 3 case. Does it make sense? By retracting the lower incisor backward, you have a much better, what do you call it? Mental labial sulcus. Good mental labial sulcus is a very essential factor of aesthetic face, which is why she looks better. She looks more beautiful than initial. Finally, we'll have to think about early treatment. Do you like her face or not? Very bad. Protrusion, hyperdivergent. Her mandible plane angle was 52 in the beginning, 9 years. What are you supposed to do? Well, I'm going to use a tongue creep because that is what is written in the textbook. I use the tongue creep. Doesn't seem to work. Grows. Oh my God. What am I supposed to do? It's a terrible growth. Very terrible growth. What am I supposed to do? Let it go and orthodontic surgery? At least we can intrude the molar. Intrude the molar. And we also pulled out premolar. Okay, Dr. Lee is in trouble. He is doing everything that he can do, everything he can imagine. This is the end of the treatment. This is the end of treatment. Okay, now we have a decent profile because of the retraction. No, it's not. It doesn't just happen by chance. Phase 1 treatment was miserable. We tried to reverse the situation in phase 2 treatment in here. Phase 1, always terrible. Phase 2, you can have a second chance. But unless you control the vertical dimension, you will be even more miserable situation. This is the difference. Have a look at the lower incisor movement. Oh my God, have you ever seen this kind of lower incisor change? This is possible because she was still young. You cannot possibly do this thing in a 30-year-old lady. And have a careful look at the mandibular plane change. Phase 1, opening. Phase 2, closure. We need a closure, conversion of the growth direction in this way. How is that possible? Because we intentionally did total arch control in this way. Okay? So many times we need very controlled, precise movement of the either upper and lower or lower incisor. And this is not possible with the surgical intervention, especially the symphysis is very thin. I have a very limited time. But you have to understand, majority of the class, phase 1 treatment tends to be extrusive. Last case, 8-year-old girl. What do you think about her face? Looks like class 3. So you will try face mask. Yes, without exception, you will try face mask to control the class 3. We had an improvement in the first phase of, improvement, class 3 to class 1. Now, let me ask you a question. Do you like her face at the end of the phase 1 treatment? Yes or no? You made it worse. No, it was me. I made it worse. I'm sorry. I made it worse because I'm the one who is in charge of the treatment. I made it worse. So, what is next for phase 2? What are you supposed to do? Very bad. Why? Because phase 1 treatment is mostly extrusive. We need to do something. We need to reverse the situation in phase 2. In phase 2. Like what? We intentionally did total arch intrusion. Okay, now I'm relieved. At the end of the phase 2, we gave a little better profile. It just happened by chance. just happened by chance? No, it is a result of the treatment, intentional treatment outcome. And also have a look at the change in the mandible plane. In the phase 1, opening, phase 2, closure. So you will have to minimize the action of the phase 1 treatment if you want a little better treatment outcome, and you will stick to focus on early phase 2 treatment to replace the surgery when it comes to hyperdivergent phase. And the mechanism is when you do total arch intrusion during active growth, you will have a combination of retraction of the lip and also advancement of the chin at the same time. And we call it 4-dimensional total arch movement. And we do semi-early phase 2 treatment so many times. Have a look at the rider over here. He's trying very hard to overcome the growth again, but doesn't work. So I feel the same thing when I deal with the hyperdivergent phase, but if you stick to the very precise control of the vertical dimension in this phase 2 treatment, you'll have a second chance. So unlike the way how it's described even in American Journal of Orthodontic and Dentofacial Orthopedics 2002, I'll make an amendment. Most of the authors tend to be very negative about the early treatment, but my proposal is a little different. Depending on the way how you do 4-dimensional total arch intrusion, you may even improve the face. This is something that is not very well described in the orthodontic textbook, and I summarized this and published this in Seminars in Orthodontics 2017 issue. Hopefully you understood the idea, and this is a little realistic, and hopefully you will enjoy the orthodontic biomechanics. If you want to know more about the biomechanics, you are very welcome to annual Yonsei University mini residency course next year in July. Please come and join, and we will get together. Thank you very much for your attention.
Thank you, Professor.